All right, so we're doing non-muscular skeletal injury or disorders, GYN and hematology today. Roger, chill, bro. It's a squirrel. Stand by. Hold on one sec. Babe! That works so well. Oh, good. Now I have a dog call and response going on right now, in case anyone was wondering. All right. Anyway, so a lot of these things, maybe the exception of GYN, there's not a lot of active treatment that we're going to necessarily do, right? A lot of these things are, again, kind of more of the long-term chronic issues where you're going to be managing a patient's symptoms, making them comfortable, and bringing it to the hospital. Yeah. So, oh, goodness gracious. All right, so quick review. Right, your skeletal system provides all of the structure for your body. If we did not have a skeleton, we would be weird, kind of amorphous blobs. They kind of squiggled around. The way that our body works in terms of movement is that it's a system like levers and pulleys, right? So you have muscles that counteract each other, right? So if you think about your leg, if you want to pick your leg up, your quadricep contracts and your hamstring extends in order to bring it up. And if you needed to bring your leg back, your hamstring would contract and your quadricep would relax in order to create movement. So if you have any sort of breakdown in that balance counterbalance action, you're going to have issues, right? Your axial skeleton, again, remember, is that axis, so your skull and spine, while your appendicular skeleton is everything else. Various types of joints. Your fibrous joints are those unmovable joints that usually you see within the skull. Your cartilaginous joints are the semi-movable ones that you kind of have in your spine, right? You have some movement depending on how good your spine is that day. And then your synovial joints, which are free-moving joints. Tendons versus ligaments, okay? That's your tendons attached to a muscle. Okay, so your Achilles tendon, right, is probably the easiest to remember. It comes up from your heel, attaches to your calf muscles. And your ligaments attach bone to bone. So if you are into any sort of contact sport, you talk about like football, for example, when they get tackled and they like sprain their ACL, those are the ligaments that hold the bone to bone together. Okay, so it's a very thick, fibrous kind of attachment that doesn't have a lot of blood supply. So it takes a little longer for ligaments to heal than other parts of the body, okay? And it's also because it isn't attached to a muscle, it's a little less flexible and it's a little less well protected. We also have our cardiac muscle, which we're very familiar with. Smooth muscle is traditionally that involuntary muscle that is along your GI tract and in your respiratory system, etc., etc. Postural maintenance is due to muscle tone, right? So you see patients who have muscular dystrophy, for example, you see that they kind of become contracted, right? They sort of kind of just fall in upon themselves because there's no underlying kind of tension in that muscle that keeps the body upright. Kind of think about when you relax, right? You know, if you're falling asleep and doing that like breathing and like you kind of relax your muscles, like there's still tension there in those muscles because they're being stretched. And this is sort of one of those important things, especially when you get into trauma. When we talk about how you know it's a femur fracture versus like a hip dislocation, is you have this muscle, right? You have this, your quadriceps is one of the strongest muscles in your body, and it's attached, it's being held taut by one of the strongest bones in your body, the femur. If that femur breaks, that muscle isn't being held taut anymore, so it contracts aggressively. So then you have these two ends of the bone that go boop, right? And that's why you get like that very violent kind of potential for very significant blood loss, because now you have these sharp ends of bones jamming into muscles on either side. But that's why that, like, if you have a patient who has a femur fracture, especially if they're younger and have really strong muscles, you'll see the whole quadricep will just be trembling, because that muscle is used to being stretched, and now it's being severely contracted, and there's nothing holding tension against it. So you're going to have like this like really wild like kind of spasm in the muscle. And that's why traction splints work so well, because now you're pulling that muscle back to its comfort zone. Okay, because, and this is like one of those like kind of sport kind of analogies, like your body is made of kinetic energy. So when you hit the ground, right, if you're running or you're, moving in any way, shape, or form, it's like this spring-loaded action because your muscles are tense. So as you move, that tension is transferred from kinetic energy to actual, movement. So just kind of something to keep in mind, especially when we get into trauma a little bit later, like how you can kind of see like muscles like to be at a certain tension point. All right, back to the screen. So yeah, so without muscle tone, we again kind of look kind of weird and saggy. Oh, anywho, so again, if we are assessing our patient, no matter what, DCAT BTLS is always a good way to assess, because you can have a patient who has suffered an atraumatic injury. Okay, you can have pathological fractures because, how many times have you transported a little old lady who says, I just stepped and I heard a pop and I can't move now? It's because, the bones start to weaken and the forces of gravity and tension start to outweigh each other. So just kind of stuff to keep in mind while you're assessing your patient. Different variations of what motion, bodily motion looks like. And this is going to be like, this vocabulary is important when it comes to taking the state test, because they will say things like flexion and extension, and you really need to understand what those are. So flexion is moving a body part towards the body, right? So you're at the joint. So if you are flexing your bicep, right, you're bringing that, you're using that lever, right? That bicep is being contracted, and you're bringing your forearm up towards the body. So same thing as if you are flexing forward to touch your toes, you are creating a acute angle at your hips. Abduction, adduction, okay? Abduction, right? If you abduct a child, you take it away from their home. So you're taking the arm or the leg away from the body, as opposed to adduction, where you're bringing it closer. Medial and lateral rotation, okay? So if you have a patient, this is especially like patella and or femur fractures or hip issues, right? So is the leg laterally rotated, right, where like the foot is turned in, or sorry, the foot is turned out, or medial rotated where the foot's turned in? And it's like helps you if you're trying to write a articulate PCR, kind of determining what the patient is looking like when you see them is important to put in there. So extremities, for the most part, unless there's some sort of underlying pathology, should be relatively proportional and symmetrical. So, and they should look the same, right? So if you have a patient who, I had a lady once who looked like she had two elbows on one side, and, upon further examination, it looked like she had broken her arm, like her forearm, and it healed crooked. So with like a long sleeve shirt on, you couldn't really see like what was going on. It healed all wrong. So seeing that should be like a clue, like you need to investigate a little bit more. Differences in coloring, right? So if you have one arm that's looking a little cyanotic or a little purple, and the other arm's looking normal color, that should be a huge sign to you that there's something going on, right? If you have one arm that's really buff and the other arm that's really not that strong looking, that's, again, another little context clue. Anyone ever see that, I feel like it's a Snickers commercial, the arm wrestling competition commercial where like the guys have like one really big beefy arm, the other arm's kind of small? Like, that should be some sort of clue, because not only does it give you a clue as to maybe there's some sort of pathological issue going on with the patient, however, there also might be like a environmental clues, right? So if this patient has a job that requires them to use one arm significantly more than the other, okay, what other environmental clues can you kind of get from that, right? Should you be asking that patient, all right, so, oh, I see like you have one really strong arm here. Like, what do you do for a living? Oh, well, I don't know, I wrestle cows. Okay, is there any way that, you got exposed to, some sort of pesticide, or, got injured at work or something like that, right? So there's a lot of openings for questioning that being very attentive to detail can really give you like a leg up in terms of determining what's going on. Various spine issues, scoliosis, right? I think that most kids are diagnosed with scoliosis, right? That lateral curvature, inappropriate curvature of the spine. Kids are kind of screened for that early on in school, so people will know if they have scoliosis. Kyphosis, right? That humpback, that's generally as one gets older and those muscles start to break down and the spine starts to curve forward. I feel like we're going to start seeing a lot more people with kyphosis in the future because of as we all like lean over our phones, right? That puts our neck in an inappropriate position. In lordosis or swayback, right? So that the spine in the lumbar region swings forward, which is usually due to very underdeveloped back muscles in that region. So then it causes an anterior pelvic tilt, right, as those iliac crests move forward, and causes all sorts of other back pain, etc. You should have a patient, if you have a patient who is not who has atraumatic, right, they shouldn't have any point tenderness along their spine. Okay, usually if there's some sort of point tenderness, that's a huge concern regarding the health of their spine. And they also should be relatively pain-free when they're going through the range of motion. As EMS professionals, I think we're all very familiar with that fact that doesn't happen every single day. There's going to be days when you're like, my back. Like today for me, for example, my back. So we were talking about this before, right? So extremities should look very similar from one side to the other. If you're looking at this picture, you see that there's this cyanosis in this patient's left leg. What does that indicate to you?
Possible cardiac or pinched vessel.
Pinched or occluded vessel, artery or vein?
Artery.
Artery, 100%. Veins will present with more edema. Okay, there'll be a lot of swelling if it's a venous occlusion as opposed to an arterial occlusion, because if you think of this, right, so an artery occlusion causes ischemia past the point of occlusion, right? If you think of this as the heart, right, this would be a STEMI leg. There's injury, right? So all that acidosis is building up in that area of the leg. But if you think of it as a venous occlusion, the venous occlusion is going to have swelling because that fluid can't get past the blockage, so it comes back from whence it came, right? Just like with congestive heart failure, okay? Also, I just want to point out, look at that very creative location that they put this IV in, down here on the bottom. If you ever ride with me on an ambulance, these are locations that I'd be like, you need to look at the whole body. But you can also see that they tried it further down and missed. But even if you look at their other foot, look at the discoloration on the foot itself, right? It's a little blue. It's a little purpley blue down there. So there might even be something else going on. Maybe it's frostbite or hypothermia, right? So these are things that you need to kind of look at. Fun little tidbit, in absence of hair growth on a patient's calves is one of the first signs of congestive heart failure, because the increase in the venous and capillary pressure starts to kill hair follicles. Bring that to Jeopardy with you when you guys try out. This is really important for us as well, especially if you're going to walk a patient to an ambulance, okay? This is a very effective, right? How is the patient moving? I don't know about anybody else, but I like when I people watch, I like to like make observations about people, right? So you always have those people who do that kind of waddle back and forth, and you're like, you're going to need a hip replacement. Or they do like an awkward swing of their leg. You're like, you need a knee replacement, right? Or they have some sort of just odd leg motion, right? It might be that they've had an amputation of some sort and they have a prosthetic leg. They might have back issues. They might have had an old injury on one side or the other. It's really interesting. I kind of just do this when next time you're out and about and like just able to see people move. And then there's going to be people who you see who just move very gracefully, right? And that just is kind of a good indicator that they've taken good care of their body. So just, it's interesting. So when you're doing a patient assessment as well, these are things that you should kind of look at. And then if you have a patient who maybe favors one side over the other, right? Maybe they, reach for things with one side or indicate or like do like the very Italian hand motion, right? Where they articulate with both hands. It's a possibility that, maybe there's a stroke going on, right? If they're only moving one side. I will say that I've found it very interesting that I've had in the past year or so 2 different patient scenarios where they called a stroke code because the patient couldn't move the one arm, and both times it was due to a fracture and or dislocation. So this is also why patient assessment is essential, because you might have a non-displaced, fracture, but the patient's favoring the arm, and it sort of presents like a stroke, but they don't have any other symptoms. So, this is where learning how to do a really good patient assessment and paying attention to detail is going to make you a really good medic. Osteomyelitis. Okay, osteomyelitis is an acute or chronic bone infection, usually caused by a staph infection. A variety of things can cause osteomyelitis. Primarily, it's due to like an open wound over a bone. This is very common in patients, right? Diabetics who stub their toe and open up a wound on their foot but don't feel it, that can go right to the bone, okay? And that bone can be turned into necrotic tissue due to, infection. So it's important that these patients do get evaluated and taken care of, because if it does start to spread, it can also turn into sepsis, okay? Again, this is one of those things where you're going to potentially have to take your diabetic patient's socks off. You are going to have to do a high-quality head-to-toe exam to kind of see if there's some sort of issue, okay? Just one of those things. Again, we're not going to do much except for maybe bandage the wound and bring them to the hospital and kind of be like, hey, it looks like they have an infection in their hand or foot or other extremity. One of the things that you do need to kind of keep in mind, however, is that osteomyelitis can also be caused by us. If you happen to be putting in an IO and you didn't clean the site well, you can cause that patient osteomyelitis in their tibia, right? Or humerus, depending on what location you've used. So this is important to kind of keep in mind. Like, there's definitely, the right way to do things, and that involves making sure that you clean the site very well before you start an IO. A lot of the times it's kind of your traditional symptoms of infection, where you're going to have potentially fever, chills, some purulent drainage, okay? Other signs of sepsis or infection, pain and tenderness to the infected area, especially like that, like redness. sometimes if it gets really bad, they might actually need to amputate, that area of the bone in order for the patient to be able to heal. This is one of those things that requires a course of antibiotics. Sometimes they do need to do surgical drainage, clean it up, but it depends on how bad it is. Bone tumors. Bone cancer is the most painful cancer that you can have ever. Not recommended. 10 out of 10 does not recommend. A lot of the times, bone tumors that originate in a bone are benign. A lot of the times, if the patient has cancer and it has become metastasized, those are the cancers, like those are the tumors in a bone that are, what we'll call it. Cancerous tumors in the bone have spread from another location most of the time. That's the poorly articulated way I was trying to say that. Right, metastasized cancer can end up anywhere in the body, okay? If it does happen to end up in the bone, it is not a great outcome, not a great prognosis. This patient could be potentially in a lot of pain because it's like kind of breaking the bone, if you think of it that way. It's putting a lot of stress on an otherwise healthy structure, and it's very, very painful. Most of the osteosarcomas are a bone marrow tumor. These osteosarcomas are usually in like the bigger bones of the body, and this is childhood amputations, right? Most of the time these are older patients, or younger patients, sorry, and these are the patients who you see who have an amputation earlier on in life, because that's commonly what needs to be, unfortunately, done to control the cancer. Multiple myeloma is a really kind of interesting cancer. It's a cancer of the bone marrow where the bone marrow makes too many plasma cells. It happens to older patients, and the problem is now you have these like plasma cells, these excessive plasma cells that are cancerous, just floating through the body. So you have a high risk of metastasized cancer because it's literally cancer of the blood. So it's just your blood becomes cancer, and it's just floating around, potentially spreading a lot of issues with lymph nodes and stuff like that. And it's one of those things that can kind of hang out in the body undetected for a really long time, because it doesn't really present with like a giant tumor or a lot of other symptoms. It's just there. Other bone tumors that are cancerous is Ewing sarcoma and chondrosarcoma, but on the more rare side. Lower back pain, because no one here has ever had lower back pain. So when we talk about back pain, we classify it as acute or chronic. Okay, so your acute pain is a few days to a few weeks. Generally, anything that lasts more than, any sort of pain that lasts more than 2 weeks, you should go get it assessed. Okay, go to a doctor and have them look at it. Most of the time, musculoskeletal pain will resolve within 2 weeks. Okay. Once it starts to continue to extend past 2 weeks, it's considered chronic. Okay, 3 months or more is considered chronic. And if it's not managed well, it can be completely debilitating, or it can progress and be even more debilitating than the first place. So it's one of those things, and I think everyone's kind of tweaked their back at one point or another, where you kind of, once you tweak it the first time, you're like, I'm going to probably tweak it again. Most of the time, it's a muscular sprain or a ligament strain, or a tendon strain. So if you are moving a patient in an inappropriate way, right, or you're twisting and pulling from a weird location, like anytime you've maybe had to get a patient out from like between the toilet and the bathtub, right? So those awkward positions where you're maybe extricating somebody down an awkward spiral staircase. These things, right, your body's moving in a way that it's not accustomed to, and it's not prepared to. So like holding something over your head at a twisting angle and trying to move it down, you will definitely find out which muscles in your back are not as strong as you thought they were. Other points of weakness that you might not even realize is that your glutes also support your back. So if your booty isn't in shape, your back can also be affected. So an interesting thing from a chiropractor or physical therapist, that if you have lower back pain, they usually look in, like, so say for example you have lower lumbar back pain, they look in your thoracic region for an issue. If you have thoracic back pain, they look a little higher up in your neck for an issue. Chiropractors and physical therapists are usually not concerned about pain around your shoulder blades or in between your shoulder blades, musculoskeletal pain there, because that's just where a lot of people hold their stress, and those are the muscles that we use the most to move our arms. So if you are experiencing lower back pain, maybe give your thoracic region a little bit of love. I highly recommend foam rollers. Do not foam roll your lumbar spine. Only foam roll parts of your spine that have the connective bones, right? So ribs, so your thoracic spine is good. Your sacral region is good to foam roll, because otherwise you can cause a lot of damage by overextending your lumbar spine. And that's your physical therapy note for the day. Other things that we're probably super familiar with, right? Herniated and degenerated discs. So the difference between a normal disc and a herniated disc is all of those little shock absorbing areas have been squished out from between the vertebrae. Okay, this is very commonly caused to undue stress or stretching and inappropriate movement, right? Anything brought to you by EMS, really. Herniated discs can, to a certain extent, actually repair themselves if you alleviate the stress on the vertebrae themselves. So chiropractic adjustments and appropriate strength training can actually start to bring some of those herniated discs back to where they need to be. Granted, it's not going to be 100%, but it can be significantly better. Because a problem with some herniated discs is in those regions that the disc starts to push out into, there's nerves, right? So I'm sure people here have had a herniated disc or have a herniated discs or bulging discs, which are, that pressure is, the disc is starting to push, but it has not fully herniated. You move in a certain way and you get like that pins and needles, or you get like a fiery nerve pain down a limb or a leg. So this is why back health is so important in EMS. Other things, degenerative discs, right? These are, your discs in your back are very, very highly composed of water, okay? So if they start to essentially dry out, they'll start to thin and they'll start to break down. Any sort of degenerative disease, there's also like a lot of just like spinal stenosis and stuff that can actually just cause extra stress on the disc and either force it out of where it's supposed to be or compress it so far that it isn't able to kind of be reinflated. Older people, what they commonly do, and so the problem is, like, once those discs sort of thin out, those little, if you kind of look in the picture, the part of the vertebrae, the little spinous processes that come off the sides, those can fuse together also if they get too close. So then you have all sorts of stiffening in the back as well. Older people who break their vertebrae, they actually will go in and insert bone cement and all sorts of other wild stuff to kind of help alleviate the pressure on the back. Just wild. For the most part, the most commonly affected herniation areas is in the lumbar spine, any of the L4 and L5 between those there, and L5 and S1. Most of the time, it's very weak back muscles that cause this pain. Any sort of low back ache, numbness and weakness in the extremities, unilateral leg pain. Okay, you can have unilateral leg pain due to sciatica without having a herniated disc. That could be caused by a various number of things. So things that I learned recently, your sciatic nerve can go one of three ways through your glutes. It can go over your glutes, through your glutes, or under your glutes. It's like a bear hunt. So depending on where it goes, it can either adhere to your glute muscles or get stuck in like the track and cause sciatic pain. So if you have that like lower back down your leg pain, it might not be your back, right? It could be just your glutes. This is why squats are important. Yes, so various things that you kind of need to take into consideration. This is like, again, you might have patients who have this complaint, but I think that we're, of all the people in the world who are going to have this complaint, it's probably you and your partner, right? You go move a patient, all of a sudden your partner's like, I can't stand up straight. You're like, oh, time for some workers' comp, right? Be careful when you lift with your legs. Back. So, interesting. Just make sure we are good about. Okay, speaking of sciatica. Right, so if you see right here on the side, I was just talking about how it kind of runs. Give me my drawing guy. How it runs through the glute right here, right? So either you can have a sciatic pain that originates here where the nerve comes out of the spine, or it can be, depending, it can be here where it runs over the iliac crest and it's being compressed by a muscle that might have adhered to it, or it could be down here where it starts to run through the glute, right? Depending on where it runs through the glute. So maybe you have been working out at the gym a lot, right? Or doing a lot of other glute work or whatever, and all of a sudden you're having this pain down the back of your leg. It could be because you have adhered your muscles to your nerves, which if anyone's ever having like weird pain down your leg, or any pain at all, and you're like, wow, this isn't getting better, highly recommend nerve flossing. It takes your nerve through its range of motion of like it's where it kind of goes, and it moves it just a little bit, but it breaks up any adhesions. So if you're having some sort of like chronic pain and like you've gone and done stuff to kind of make it better and it hasn't gotten better, highly recommend looking up nerve flossing for whatever body part is bothering you. Sidebar, things I've learned over the years. Cauda equina syndrome is kind of one of those weird, interesting little tidbits that you can kind of find every once in a while. I actually, my dad works with somebody who has Cauda equina syndrome. So basically, your spinal cord as we know it ends around T12, and then when it comes through the lumbar region, it starts to create this horse tail. Okay, yeah, you still have a bit of the spinal cord, but it starts to separate, and Cauda equina means horsetail. So it starts to kind of go out all over the place in less of a strict spinal cord fashion. So as it does that, it's actually a little lower. It's in the lumbar region that the Cauda equina starts. Sorry. The nerve roots can become paralyzed. The parts of the body that are generally innervated by the Cauda equina is all in the genital region. Okay, so like the inside of your thighs and the genital region. So it can cause a lot of bowel and bladder dysfunction, and loss of sexual sensation. Just basically, if you think of all the areas on your body that hit a saddle if you are riding a horse, that's the area that becomes paralyzed or kind of numb. So it can be caused by trauma, it could be caused by nerve compression, it can be caused by a number of different things. So fun fact. Any questions or concerns, thoughts before we move on?
I'll just throw one out there if I can very
Sure.
quickly. One story from the weekend: a kid, 17-year-old autistic kid, at a house party in the evening when it was dark, decided to jump on a trampoline,
Oy.
do a it was a 180, he called it. So it's like a backflip with a half twist with the sneakers on. He lands wrong and snaps his tibia clean.
Nice.
We get there. He's right in the middle of the trampoline. So it took us about 30 minutes to extricate, administer 60 mics of fentanyl, 30 up front, 30 on the back end. splint, remove, and get him into the hospital and take him over to Stony Brook. It was just an absolutely beautiful case to work on.
Except for the whole getting him off of a trampoline, which sounds like a pain in the butt.
Well, I have 4 children, and we had a trampoline, so I am versed in how to exit and enter trampoline with minimal movement. So that I went to the far side as far as I could. I sat on the edge, and then I did this little log roll.
All right, so you're going to be teaching the CME, the trampoline extrication CME, later in the year.
That's what made it so much fun.
Yep.
I love when these life experiences contribute to the rescue of others.
Oh, absolutely, absolutely. There's
But
a lot of.
the other thing was it was so dark, you couldn't see what was going on. So we had to adjust. You know, we eventually got flashlights and everything else in there, but you couldn't really see the deformity until you adjusted to a particular position.
Oh wow.
Yeah. So.
Cool.
Thank you.
Yeah. All right, so joint disorders. The most common joint disorders you're going to see are osteoarthritis. Okay, arthritis itself comes in various different forms. You have osteoarthritis, rheumatoid arthritis, septic arthritis, and then gout. But osteoarthritis is probably the number one most common thing that you're going to see. It's a degenerative disease, something we can all look forward to, especially if there's some sort of repetitive motion. Osteoarthritis is almost always asymmetrical. So, for example, my dad works for Coca-Cola as a delivery guy, right? So his traditional movement when he's moving soda is that he takes his right arm and he pulls it down onto the hand truck, right? That repetitive motion. So now his right hand hurts, okay? Especially when he wakes up. His shoulder hurts, right? Because you're doing a lot of this. At least in EMS, we're kind of doing hopefully bilateral movement, right? The stair chair, the stretcher, everything's like 2 hands, 2 arms. But there's always like in your life, there's always some sort of like unilateral motion where you're putting one side at risk more than the other, right? Are you a righty or a lefty? Writing, right? Holding a pen or a pencil is going to cause joint degeneration on one side versus the other. Just random little stuff that pops up in life. Rheumatoid arthritis, on the other hand, is an autoimmune disease that attacks the joints. It causes an inflamed synovium, right? So every movable joint has what's called synovial fluid inside the joint. That fluid is in like a little capsule, and it helps kind of allow joints to glide. When you have an autoimmune disease such as rheumatoid arthritis, it does open up the areas for different issues. Okay, once something is inflamed, it just has a problem altogether. Rheumatoid arthritis is commonly associated with extremely disfigured joints. So yep, little compare and contrast, right? Joints become swollen and puffy with rheumatoid arthritis, where you might just have pain and stiffness in an osteoarthritic joint. Septic arthritis is due to an infection in the joint, which potentially could be due to, say, for example, osteomyelitis, right? If that infection starts to spread up the bone and get into the joint, it could infect that joint area, the synovial area, and create septic arthritis. And then you have gout, which is a little bit different. It's classified as an arthritis, but it's more of a deposit issue, which can be cleared up with medication. So almost, I'm going to say 98% of the time, gout is caused by uric acid crystals. Okay, every once in a while it's caused by calcium crystals. But those uric acid crystals deposit themselves around the joint, usually the big toe because gravity. And it causes pain because now think about it, you have like what was once a very smooth joint that's now covered in crystals, so now it's kind of pointy. And you're putting all your weight on it because it's on your big toe, so it's super painful. Moving on, muscle disorders. Myalgia. Myalgia is any pain in the body, okay? Myalgia just means pain, right? Fibromyalgia is nerve pain. Myalgia can be caused by a number of various things, right? Overuse. You CrossFit one too many times this week. You could have an injury. Again, you CrossFit one too many times this week. You might be sick, right? You might have the flu, right? You might have the COVID. Nobody knows. But it causes that ache and the pain of muscles. There are a number of remember myo is a muscle. Inflammatory issues that attack the muscles themselves, okay? For the most part, the progressive muscle weakness brought on by inflammatory myopathy starts in the core and moves outward, okay? As opposed to muscular dystrophy, which we're going to talk about probably in a little bit, if I remember correctly, starts in the extremities and works its way in, okay? Usually it's associated with fatigue after walking or standing or any sort of exercise, difficulties in swallowing and breathing, because again, remember, those are your muscles. Those muscles help you do those things. Dermatomyositis, it's a mouthful, is an autoimmune disease. It's one of those inflammatory myopathies, and it traditionally will attack the trunk muscles. Okay, so those muscles that help you sit up, move, right? All of those things. Commonly, you will have the patient will have a rash before they start getting the muscle weakness, and it's usually on their like their joints and across their face, right? So that face discoloration can be confused for lupus, right? Remember lupus, we have that butterfly look across the nose and the cheeks. Dermatomyositis has a similar looking rash, but it's more up in like the eyes than in the face. Interesting fact, dermatomyositis as an autoimmune disease can also be brought on by a previous infection. For example, my grandmother actually had dermatomyositis, but she had polio before as a child. So the dermatomyositis attacked all of the muscles in her body that had been affected by polio. So it was just really interesting to kind of see, and they called that post-polio syndrome. Okay, so basically any sort of infection that attacks previously polioed muscles. Polymyositis is bilateral muscle weakness, right? Traditionally in like the lower extremities and the trunk again. It can progress upwards more, but usually you have patients who are having a hard time with stairs, rising from a lifting position, right? All of those glutes, hamstrings, quads, muscles. Myositis is just overall muscle disease. Muscle wasting usually starts in the wrists and fingers. All those little tiny muscle, what's the word I'm looking for? Dexterity issues, right? Chronic fatigue syndrome. So, chronic fatigue syndrome, also called myalgic encephalomyelitis. It's commonly if you are extremely tired for more than 3 months at a time and no amount of rest that improves it. Okay. They aren't really sure what causes it. There's a number of different kind of theories on what it is, that it's a change in your energy production because of your mitochondria. It could be an autoimmune problem. It could be stress or genetics. In terms of infection, mononucleosis has been linked to chronic fatigue syndrome. Mononucleosis has also been linked to multiple sclerosis. They don't really know what causes it, so they don't really know how to fix it. So this is one of those things where the doctors kind of shrug and go, I don't know. Try hard to feel better.
EMS causes it.
Yo, shift work. Shift work has been known to cause all sorts of damage to you as a human being. It's not good, especially if you work nights. It throws off your whole circadian rhythm and like cuts years off your life. So, daytimes. Random other overuse injury or overuse conditions, bursitis. So around all of your joints, you have these little tiny sacs. of fluid called bursa. The bursa keep your muscles from rubbing against the bones, okay? It's sort of like a tiny airbag, if you think about it that way. It just really keeps all of your ligaments and your tendons and your muscles from rubbing against bones and other connective tissues, so that you kind of can move with grace, freedom and grace. Bursitis very commonly happens at like the knee or the hip, depending, or the shoulder, depending on what your sport is, right? It's a repetitive stress. So this is why in high school they try really hard to not have high school baseball players, for example, pitch too much, because they'll develop this overuse injury like bursitis that can be debilitating and pretty much ruin their career at 16. Okay. Again, the same thing, or they don't want, like, runners, high school runners, they don't want them to specialize in a sport too soon, because they don't want them to be like have these like muscular imbalances that lead to some of these overuse issues. So bursitis can be very cause like some swelling of the bursa, tenderness in the location.
I had it in my elbow from wrestling.
There you go. It's one of those repetitive, like, especially like if you hit it, like if you're wrestling, for example, you hit the elbow and then you're still doing like that range of motion. All of those things can cause bursitis, and it's painful, and like anti-inflammatories kind of work for a certain extent, but not wonderfully. But what are we going to do for it? An EMS, as an EMS response, what are you going to do for it?
Ice.
There you go.
Painting.
Ice. BLS level ice. You don't really need, I wouldn't even give this patient like pain management, honestly. As opposed to muscle strains, depending on how bad it is, right? I think everyone has had a muscle strain at one time or another. So every time you exercise, you literally strain your muscle. But for the most part, it's at this level 1, grade 1 pull, right? You cause these little tiny micro tears in your muscles. And as you start to maybe lift more weights or exercise or push your body more, those little tears start to repair themselves and they become a bigger muscle. That's how you have all these dudes who look totally swole, is that you're causing these little tiny muscle strains that then repair to a bigger muscle, okay? However, if you go a little too far, you can weaken that muscle by tearing it, okay? Or completely avulsing it where it's detached, right? Which highly recommend not doing. And this is one of those weird things where people are like, oh, it's just a muscle strain. I would rather break a bone than strain a muscle. Bone, very straightforward, right? It heals stronger, and it takes 6 to 8 weeks. A muscle, when it heals, it's not the same. It's never the same. It just has like a weak spot, right? I think everyone ever like kind of pulled a muscle, like it takes quite some time for it to be kind of okay, and then like you move the wrong way and it's like, and you're like, oh, that hurts, oh, what did I do? And you're back to where you started, right? You just spent like 6 months trying to rehab this muscle, and now you're back to square one because you like sneezed wrong. So I would rather break a muscle or break a bone than tear a muscle. It sounds retarded, but truth, y'all. Anyway, so yeah, you have different levels of muscle strain, right? And if you have somebody who does actually avulse their muscle, you're going to see like a weird bunching, because the muscle is going to contract. Again, kind of back to if the bone isn't intact, the muscle will contract because it's not being held to the appropriate tension. If the muscle is fully avulsed from its insertion point or where it connects, it will contract up, and when they have to go in surgically and pull the muscle back to where it needs to be. No, thank you. Tendinitis, again, super common. Repetitive motion. It's where that connective tissue, right? So instead of you actually tearing or injuring the muscle, you tear or injure or strain the tendon itself, where it connects the muscle to the bone. common tendon issues, Achilles, hamstring, rotator cuff, okay? Again, have an ice pack. It's going to be the best for you. Or rice. When it comes to bursa in particular, you want to have good padding around the joint itself. But rest, ice, compression, elevation, NSAIDs. Again, anything more than 2 weeks, it needs to be checked out. So if you have a patient who's complaining about some sort of pain that's been going on for a longer period of time, then it could be something much more serious than they think it is. Questions, thoughts, concerns, recipes? Cool. Nerve syndromes. Carpal tunnel. So, super common. If you, right here, there is a very thick fibrous band of tissue that goes right across your wrist right here. So if you look at your hand, all those little tiny bones are like from here up, right? And then you have like your phalanges and your carpals that are over here. So this very thick tissue actually can compress the nerve if it gets inflamed, and it's called carpal tunnel syndrome. Not the best design feature in the human body. It's up there with the way the femurs are designed, where I'm like, who did that? That was not a great idea. Let's make that suspension system really narrow. Not a good plan. So we have this really thick fibrous tissue. If it gets irritated from things like, I don't know, typing, it will compress the nerve and you'll get tingling in the hand. Traditionally, it's in these fingers. Okay, it's usually the radial nerve that gets compressed, and then the median nerve. So the median nerve innervates the palm, the radial nerve innervates your thumb, your index finger, your middle finger, and half of your ring finger. The ulnar nerve is traditionally not affected because it doesn't run through the carpal tunnel. Okay, so you'll still have sensation in the other half of the ring finger and the pinky. Thank you for coming to my TED Talk. You can also have cubital tunnel syndrome, which is the other side. So if typing like this causes an issue, motions like this can cause cubital tunnel syndrome. So there's another fibrous band here, and it compresses the nerve on this side. Same issue where you have like a kind of numbness, tingling in the hand. This is not fun. So yeah, so thumb, first 3 fingers, sensation and motion are affected. Moving on. Ulnar nerve entrapment, okay? The ulnar nerve runs on the outside. So we just talked about, right, it controls the outside part of the hand, the pinky and half of that ring finger. It runs down through this, right here, right through this part of your elbow. It's equivalent to your funny bone, okay? So, right, you whack right there, and you get the pins and needles. That's your ulnar nerve that you're whacking, okay? So it can get entrapped, especially if you have a patient who maybe broke their elbow or has some sort of injury or swelling to this part of their arm. So as it goes through, it can get entrapped and then cause that numbness and tingling down this aspect of the arm into the pinky. Again, what are we going to do for this? Not much. We're going to recognize it. We're going to bring them to the hospital and let them do it because they have way more student debt than we do. Soft tissue infections, fasciitis. One of my absolute favorite things, and one of my favorite things is necrotizing fasciitis, which is rare, but just like one of those things that you're like, you go to urgent care and you're like, I have an infection, it's necrotizing fasciitis, and they look at you like, what? And you're like, nothing, just seeing if you're on your game. I'm that person. I had a finger infection. You can kind of see it's like all jacked up. My finger's all weird shape. And I'm like, I was just concerned it was necrotizing fasciitis. Do you want to drain it for me? And he's like, who are you? You know too much. It's always fun to go to urgent care. So fasciitis, right? So the fascia is this like very thick tissue that runs around your muscles. And it also connects, especially on the bottom of your foot is really where you're going to see this pain the most, is plantar fasciitis. Is a very fibrous tissue that goes across sort of like a hammock on the bottom of the foot, okay? And when it becomes inflamed, it can be very, very painful and unpleasant. You'll see this in people who have like repetition or very flat feet. So people with flat feet who do repetitive motion kind of end up with plantar fasciitis because that fascia is doing everything it can to give your foot an arch, okay? Because that arch is sort of like the suspension system in addition to your stupid hip, which is just poorly designed. So as you have this fascia that's trying to create this shape, it gets tired, it gets inflamed, and then you have foot pain. It's usually bad, like right when someone gets up in the morning and they like the first few steps, they'll have like this really severe foot pain because their fascia was like, yo, we were chilling, we were good, and now you want to walk again? What's this bullshit? So, very sassy, the fascia. Again, this can happen in a lot of other areas in the body as well, but it's really just you'll see it the most in the foot because, again, it is supporting a lot of your bodily weight. NSAIDs. NSAIDs is fantastic. And as I said, necrotizing fasciitis. So it's an anaerobic bacteria. This is why necrotizing fasciitis is so dangerous, is because it's usually introduced into the body, into the fascia, through a puncture wound. So people who like, oh, I was at the beach and I stepped on something and it kind of hurt, but I just kept going on with my life. And then all of a sudden they have like this like kind of pain in their foot. And it just all of a sudden gets a little red. And they're like, oh, it's a little infection, no problem, right? It'll just go away. And then it just gets more red and it keeps going up their leg. And they go to the hospital and they're like, yeah, we have to cut your leg off. Whoa, that escalated quickly. What happens is this anaerobic bacteria starts to spread very aggressively along the fascia, right? So that tissue, that fiber that is surrounding the muscles starts to become infected and then become like gangrenous. And it becomes very necrotic and just gross and slimy and not helpful. So what they have to do is they actually have to open up the limb, whatever body part is being affected, because once that anaerobic bacteria is exposed to oxygen, it starts to die. So debridement is essential, but it's also about catching it as being necrotizing fasciitis, because it also is so kind of like infrequent that people are like, doctors don't really necessarily pick up on it. They're like, oh, it's just a little like osteomyelitis, there's a little cellulitis, a little skin infection. Meanwhile, under the skin, there's like all sorts of nonsense going on. It's just not good for you. What else we got? Moving on. Necrotizing fasciitis. In case anyone ever wanted to really know what testicles look like without friends, there's that picture for you. So yeah, necrotizing fasciitis is pretty vicious. Causes a lot of issues. Gangrene, another personal favorite. Usually it's caused by a decreased blood supply to a body part. Most of the time it's toes. Most of the time it's diabetic. Other things that can cause gangrene are frostbite, right? So you have this, the tissues aren't getting blood flow. They start to go to anaerobic metabolism, and all of those toxins start to build up, and then you can either get wet gangrene or dry gangrene. Okay, wet gangrene is very gooey. Dry gangrene kind of looks like this, where you get that weird mummified looking toes. Again, what are we going to do? Treat the patient and their symptoms. Okay, so if this patient is now septic because of gangrene, you're going to treat them for sepsis. If the patient's like, I think my toe fell off, you're going to take the toe with them to the hospital. Okay, it's recognizing the bigger picture that's really essential. There's that dry gangrene. Dry gangrene is not commonly caused by an infection. It's just the reduction of blood flow through the arteries. This can also, not only can it cause like, arterial sclerosis, diabetes, cigarette smoking can cause it. IV drug use. Okay. One of the medics at Jamaica brought in this lady. This was a few years ago. Her hands, all of her fingers were dry gangrene, and they like were falling off. Like her fingers were like just kind of falling off as they got her to the hospital. They got into triage. And they're like, what is this? And they're like, oh, you haven't seen her toes yet, because her toes were doing the same thing. Because she was a bad IV drug user, and she was injecting like under her fingernails and in between her toes, and just caused so much damage from the drugs that her finger were just falling off. And she's just chilling, like, yeah, no, whatever. Like, it's fine. I'm good. And just falling off. I'm like, someone take a picture of that. I'm gonna save that one for later. Yeah. You can really mess yourself up with drugs. Don't do drugs, kids. Wet gangrene is commonly caused by an untreated infected wound. Um, it, so it's commonly caused by Clostridia, which produces this poisonous toxin and gas. So that gas builds up under the skin and helps kind of give it that swollen look. It's just not sexy. Don't take care of yourselves. I can't say this. I can't. This is talking about the little nail infection thing that I had. This is an infection of the cuticle bed. This is what I had. And ironically, I didn't even bite my cuticle on this finger. So like, if you had your hands submerged in water, right, you're giving the bacteria like a good location for it to kind of propagate. Ironically, they tell you to soak your finger in Epsom salt. Like, shouldn't we not be soaking the finger? So yeah, fun. I can't. Paranitia? Paranitia? I can't. Again, what are we doing? We're taking it to the hospital. We're going to let the hospital deal with it. They need some antibiotics. This one's great. Flexor tenosinovitis. I can't. Tenosinovitis. That was a mouthful. The tendon, you have a patient who ends up with like these like flexed fingers because the sheath along the tendon becomes inflamed through the bacteria. It's a surgical emergency because if you don't fix this, you end up being a Bond villain for the rest of your life, okay? You just end up with a clawed hand. And unless you also have like a fluffy white cat, like that doesn't really work for a lot of people. So they need to go in and they need to clean the the fascia, the tendon sheath, to make sure that it doesn't claw. Yeah. So again, the patient will have swollen digits. They'll have a lot of pain, a lot of tenderness. You don't want the tendon to die because of the bacteria. Again, this is really commonly, you would potentially see this in a patient who may have had a puncture wound or an animal bite to the hand, or the foot, but usually the hand. Oh, is that it? Cool, that's it. All right. Exit. Stop.
So Nicole, I have a question for you.
Sure.
So in those gangrenous examples, it seems, I mean, diabetes, I know that, frostbite, drug use. I mean, most people would, aside from the frostbite issue where they might get stuck out in a situation that would cause that, I mean, most people would, I would think, obviously tend to something they thought was going to be a problem. These are clearly people who have neglected themselves.
I was going to say, you have a really high expectation of people.
Let's just let your toes turn black until, I mean, if I were an IV drug user and I had to have a place to put my drugs, I would want to take care of that place, or,
No, because once you get your high, you don't care anymore. That's the problem.
Yeah.
Also, nursing homes and gangrene. And that kind of comes back to this isn't my patient. I don't know. I just got here. This patient's new. Whatever other nursing home excuse that you kind of have. That's where I've had gangrene. A patient with a gangrenous foot, her whole foot. Like, it was her entire foot and about 3 or 4 inches up her ankle. And they're like, I don't know what that is. She's septic, right? She's full-blown septic now. She's unresponsive. And they're like, oh, I don't know. I'm like, oh, well, this didn't happen overnight. And this is sometimes why I'm not allowed to be unsupervised, because then I start sassing people. I'm like, clearly this didn't happen overnight. Like, this was here for a while. And you change her and you turn her and you do all of these things, and what, we just like close our eyes to the dead black foot that she has? Like, how do you get away with that? And it's just neglect, like 100% neglect. I had another lady who, she was again full-blown septic. Her one toe she was a diabetic, poorly controlled diabetic, didn't take good care of herself. Family was like, whatever. Her toe was completely black and she was unresponsive and her sugar was in like the 500s. And I'm like, okay, well, that toe's coming off. You'd be amazed at the people who just kind of go, it's fine, it'll get better.
So you brought me to my next question, which is if we see, I mean, I see an older person that neglect themselves, that might require some like reporting to get them some assistance for care. But in the settings that you're suggesting, nursing home or home care, I mean, that's a more serious matter, is it not, for reporting purposes?
Oh, absolutely. But good luck getting in touch with Adult Protective Services. That's one of the That's one of the most challenging places I've ever tried calling.
Okay.
So, 100% would recommend doing that. Or talking to the hospital when you get there, like social services, like, listen, this patient cannot go back. They cannot go
Right.
back to that house. But again, they only do so much. Because what are you going to do? Send the patient to a nursing home? Patient doesn't want to go. Patient can't afford it. Patient, any other number of things. But like, it gets to a point sometimes where it's like, yes, people have free will, but at the same time, like, they also aren't necessarily taking care of themselves. And you're like,
Gotcha. Thank you.
yeah, no problem. Thoughts, concerns? Again, the main part of medical emergencies is recognizing what's going on, but also looking at a bigger picture and managing the patient. Because does it really matter if the patient has dry gangrene or wet gangrene if they're altered mental status and has a blood pressure of 80? No. Do we have a gangrene protocol? No. We have a sepsis protocol. So we manage the patient with sepsis. And I think it's more important that you can recognize sepsis and the signs and symptoms of sepsis than a random finger infection. So, thank you for coming to my TED Talk. Now let's do gynecology. Woo! Who's excited? Work. Okie dokie. Gentlemen, pay attention. I joke. This is what the female reproductive system looks like. You would also be wildly surprised and a little bit disappointed in realizing that there is a very large percentage of women who have no idea what their body does, what it looks like, or how it functions. It's America. Hashtag America. We do not teach children appropriately in school because we're so afraid of the whole idea. We're too Christian. This country's a little too Christian. We act like if we tell people abstinence is how it's going to work, that people are going to listen. Hormones override abstinence a good percentage of the time. But then people don't know what their body does and how it functions, so they can't do things wisely. Anywho, various parts of the female reproductive system do various different things, right? So you have your ovaries, which produce eggs, the fallopian tubes, which are the highway for the eggs to get to the uterus. The uterus is where babies are made, okay? And the cervix is the door to the uterus. When a woman is pregnant and about to give birth, this is the part of the body that we call it aphases. It stretches to about 10 centimeters to allow a human to pass through it. The vagina is then the receptacle / doorway for babies / penises, and or whatever other random things end up getting put up there. Don't do that. Random things such as potatoes and whatnot have been left up in vaginas and grown and caused all sorts of issues. The internet is a wild and wondrous place. The normal menstrual cycle is about 28 days, okay? So that is from the first day of menstrual flow to the next menstrual flow, okay? Menstrual flow is about 25 to 60 milliliters of blood, mucus, and other cellular debris, okay? The uterus is a pretty wild place where it will kind of make itself a very loving, nurturing home for a future baby, and then it sort of just throws a temper tantrum when it realizes that no baby was made. Women who are on birth control tend to have a lower menstrual flow because the hormones that are hormonal birth control, I should specify, hormonal birth control kind of tells the body that, hey, you're already either already pregnant, or hey, you're postmenopausal. Okay, so it doesn't need to make as much, so that lining that's being shed every month is less. Women who have had their cycle for a number of times, right? So I'm not going to say like, the younger group know what to expect. So if something is wrong, they know it's wrong. Okay, believe them. But specify and find out what is different. Well, I've been bleeding for 28 days. Oh, that's new. Okay, has anything changed? Certain blood or birth controls, right? There's an injectable birth control called Depo-Provera, which is a progesterone based birth control. Depo-Provera, a lot of women who have that injection, they won't get the whole idea behind Depo is that you don't have a period. However, it takes about 3 months or 3 different injections for it to start working. One injection lasts 3 months, so then it needs at least 1 full cycle of that Depo, and then again. And you can't take any other birth control if you have the Depo injection. And there's been people who've taken Depo and bled for 3 straight months. Okay, so that opens up the door for other problems. For example, I don't know, anemia. Women are kind of at a baseline anemic state as it is because we bleed every month. So, it could cause all sorts of issues. A normal tampon or pad can absorb about 5 milliliters of blood. This is important when you're assessing your patient. So if you have a woman who's saying, listen, I've gone through 10 pads this past hour, that's 50 milliliters of blood, and that's kind of more than they should already be bleeding, right? Especially if it's 60 milliliters over 6 days. That's 10 milliliters of blood a day, all right? For max, if you max that out. If you're doing 50 milliliters in an hour, there's some sort of hemorrhage going on, okay? Knowing this number can help you gauge how much bleeding is going on and determine how serious this situation is. There's 2 phases in a woman's cycle, okay? It's the follicular phase and the luteal phase, okay? During the follicular phase, this is the first day of the menstrual cycle, follicle-stimulating hormone and luteinizing hormone are released, okay? So this is what tells the ovaries it's time. Release the ovum, okay? And that sort of starts to go and work. The body starts to say, okay, we're going to release an egg. I need about 2 weeks to prep it. And it's like, okay, cool, no props. So the body's like, all right, cool. Here's 2 weeks of this kind of lower body, basal body temperature, this sort of steady state level of hormones, and then the egg is released, and the woman enters the luteal phase of her cycle, which is another 2 weeks of fun and excitement. This is the PMSy stage, right? If you look at how the hormones are kind of squiggling all over the place, welcome to why we PMS, okay? We're like, whoa, what's going on? What's going on? I don't know. That's just hormones, okay? The body's like, this is the fertile time. Let's make a baby. And then most of the time, women are like, nah, we're good. We're good. We're not ready for that. I like having money. So during this like from when the ovum is released to like the first week, the first couple days is the most fertile period of time. Okay, and then this is while the ovum is still in the fallopian tubes. Okay, fertilization occurs in the fallopian tube. Remember that because it's going to come into play later on during this journey. If it's not fertilized, it does not adhere to the uterine wall when it gets there, which means that no baby has been implanted, which means that at the end of 28 days, another 2 weeks, menstruation starts, okay? And then we do the whole cycle all over again, okay? Hours of fun. So luteinizing hormone and follicle-stimulating hormone come from the pituitary gland, okay? While estrogen and progesterone come from the ovaries themselves. If a woman is pregnant, the placenta also generates hormones, primarily progesterone. Okay, because if it keeps, see how the progesterone starts to swing up right around the time when the egg is released. If the egg is released and then fertilized and adheres, this progesterone level stays up. Okay, that's what increases the fertility. Doop, 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 doop. We're not going to kind of go through that. The one hormone that they test for in pregnancy tests is human chorionic gonadotropin, or HCG, which is just a lot less of a mouthful. Okay, this is as I said, this is what they detect when you pee on a stick. Okay, if that's not there, you're not growing a human. Though it has been found that some women don't produce high enough levels for the pee on the stick to really recognize it. This is why there are some women who don't know that they're pregnant. There's also women who have posteriorly tilting uteruses who won't necessarily show while they're pregnant. And they won't even necessarily know that their uterus is leaning backwards, okay? And then the baby sits way farther back and it doesn't show the traditional pregnancy body. Hormones control everything. It's lots of fun. Hypothalamus, anterior pituitary, and ovaries are your main friends in this journey. We're not going to really go into this, but the endometrium is stimulated to grow by estrogen and continues to grow because of progesterone. Endometrium can escape from the uterus. This is called or it can become really bad inside or just outside the uterus. This is called endometriosis, okay? It takes a woman an average of 7 years to be diagnosed with endometriosis. Now think about if you have some random tissue in your body that grows every month, causes you pain because it's in a strange place that it doesn't belong, and then shrinks, and then grows, and then shrinks, and 7 years of having pain every 2 weeks because of some random tissue in your body that's growing and adhering to your other bodily organs, it's unpleasant. And to think that women have to wait 7 years for an accurate diagnosis so that they can actually get treatment, which is usually the removal of the tissue, which then also leads to the breaking down adhesions, right? So that endometriosis can cause intestines to adhere to each other. So every time you eat, you're in pain, okay? Not pleasant. We're not going to go into this. It's not really that important. An unfertilized ovum can only survive for 6 to 24 hours, okay? So this is why it is important when people are trying to have a baby that they understand when ovulation occurs. Alternatively, it is also essential for a woman to know when ovulation occurs so that she doesn't get pregnant, okay, if that's not her purpose. So if you know what day that you're ovulating, you can kind of be like, all right, cool, the day before, the day after, no sex, we're set. Because while an unfertilized ovum can only survive for 6 to 24 hours, a free-roaming sperm can survive for about 48, I believe. Anywho, gynecological emergencies. 12 to 51 is the average, it was considered a childbearing age. And let's talk. That can be much lower, and that can be also higher. Girls these days are getting their first menstrual cycle or their menarche as young as 8 due to the hormones that are in foods that we have. And the earlier that a girl goes to her first period also indicates the earlier that she'll go through menopause, okay? And the earlier that you go through menopause, the more likely that you'll have heart disease, because remember, estrogen is protective. Knowing when a girl has her first period is important. In some instances, a girl can get pregnant before her first period, okay? Because you have to ovulate before the first period happens. Does that make sense? So if a young girl is for example, a victim of sexual abuse, she can become pregnant without ever having a period, okay? On the other hand, women can also have a period that goes well into their 50s, into their 60s or later. There was some woman in India who had a baby in her 70s, right? So we can't necessarily say for sure that, there's a be-all and end-all time frame on it. This is why it's important to ask a woman if she is still getting her period. Menopause is considered officially complete when a woman has stopped having her period for 1 full year, 12 calendar months, okay? Because she might, as a woman moves through menopause, it might become more irregular, so she might not have a period every month. It could be every 2 months, it could be 3, it could be completely irregular, but at that time, it means that she can still get pregnant. Pelvic inflammatory disease, okay? Soraya asked me a great question the other day that if this is also considered an issue for men. I don't think so, in so much as all of men's sexual organs are external, and this is an internal issue, unless, I guess, of course, it is a homosexual man who is the catcher, not the receiver, is a possibility for pelvic inflammatory disease. So basically, there is a sexually transmitted bacteria, usually gonorrhea or chlamydia, that has gone untreated and creates abscesses and infection all across the reproductive tract, as well as anything else in that pelvic region, okay? Most of the time there is a purulent vaginal discharge, a very high temperature, pain with intercourse, and pain with ambulation. It's called the PID shuffle. So the woman will be like kind of bent over because now all of that infection in that uterus and that lower pelvic region is just bent forward because it's adhering. All those like internal organs down there are adhering to each other. Extremely painful. And that also means that hip flexors, which are kind of in that same region, are also inflamed, right? So if you think about it, you won't be able to stand upright and like bring your knee to your chest because of all that inflammation and pain. Just little tidbits for you. Pelvic inflammatory disease is increases a woman's risk for having an ectopic pregnancy because of all the adhesions and strictures that occur due to this infection. Moving on. Bartholin abscess. So there are little cysts, or not little cysts. What are they called? Little glands on either side of the vagina that actually help in lubrication. If one of them becomes, those little glands becomes blocked, it can cause what's called a Bartholin abscess, okay? Because it could become inflamed, not only inflamed, but it can also become infected. It's one of those things that needs to be lanced to be dealt with. If it's not infected, it's a cyst. If it is infected, it's an abscess. Vaginitis. There's a couple different types. There's bacterial vaginosis, which is caused by random bacteria. Candida, which is a yeast infection, which is relatively common in women, and can be treated over the counter with a little bit of monostat. It's usually discomfort, burning with urination, itchiness, inflammation of the labia or perineal area. Most of the time, women who are postmenopausal or postpartum have these issues because of those giant swing in hormone changes, as well as like what's the word I'm looking for? Like temperature and like lubrication, kind of, I guess. Wetness is really the problem, right? Because these things like to grow. These bacteria need a happy home, and it's usually a wet and hot location. Dysmenorrhea is considered pain during menstruation. A lot of women have dysmenorrhea, and it's just kind of common. Most of the time, it's considered to be an issue due to the muscular contractions of the uterus. Most of the time, women are able to manage it by themselves because they know it's normal, and they just take some NSAIDs and call it a day. If it's new, right? If you have maybe a younger girl who's just getting her period and she's having a lot of pain, that's going to be an issue. That might be something bigger problem, just needs to be addressed. My favorite German word, Mittelschmerz. Mittelschmerz is called middle pain in German. It is a unilateral pain with possible bleeding, happens around the mid-cycle, or I don't know, when the egg is released from the ovary. So basically it's a little ovulation pain. It's your ovary going, hey girl, guess what? 2 weeks you gonna bleed. It's usually just not a big deal. It goes away relatively quickly, but can be mistaken for things like an ectopic pregnancy or a fallopian tube rupture or ovarian cyst or an ovarian torsion. So your ovaries kind of dangle in this really kind of wild looking vibe here. But every single time a woman ovulates, she creates a follicular cyst, okay? And that follicular cyst ruptures to release the egg. And then it closes back up and it goes through this process of kind of cleaning itself up. If it closes back up and it continues to fill with fluid, it can actually pull the ovary down and create a lot of pain. It can also cause torsion because of that weight of that cyst. If that cyst ruptures, it can cause an extreme pain and it can cause significant hemorrhaging depending on like where it's located and at such. So again, this is why we always take that lower pelvic unilateral pain very seriously. Ovarian torsion, okay? The ovary will kind of twist. It'll twist along the either the tendon that's there, the blood supply, the fallopian tube, or all of the above. Okay, various things can cause this, including, as we just said, the ovarian cysts, trauma. Young girls can have this problem. Usually, when they start exercising, it's more difficult to assess than a testicular torsion, obviously, because it's internal. And if you suspect an ovarian torsion, you need to advocate for that patient, because there's a lot of times that this pain goes unrecognized. And it kind of goes back to that idea that women aren't really in pain. Okay, there was, I think it was the Atlantic. This woman was a writer for the Atlantic, or her husband was, and he wrote about his experience, or their experience, with her ovarian torsion. She had gone to the hospital with severe unilateral pain, and they put her in a corner and told her that the pain was in her head. 12 hours later, they had to remove her ovary because it had died because of the torsion, okay? But they hadn't done anything for her. They didn't give her pain meds. They didn't do imaging. They did nothing. Okay, this is one of those pat little girl, you're okay, walk it off, it's in your head. So if you do suspect that there's any sort of like serious issue for your female or male patient for that matter, you need to advocate for them. Cystitis is also known as a UTI. This is commonly an inflammation of the bladder lining. Again, women may or may not have that frequency or burning sensation. Some women are more likely to have a UTI than others, depending on sexual habits and hygiene habits. And once you have one UTI, it's really common that you'll have another. Endometriitis is an inflammation in the inside lining of the uterus, usually due to infection. It can happen after childbirth or abortion because of placental tissue, and this is why it's important for you to bring the placenta to the hospital for an out-of-hospital birth, because they make sure that the placenta is whole. Because if there is a piece that is still attached to the uterus, it can either cause serious infection or hemorrhage. Okay. Similarly to any sort of vaginosis, there could be a discharge, fever, and pain. The difference between endometriitis and endometriosis is that the endometriitis is more commonly inside, whereas the endometriosis kind of extends past the uterus. We talked about this already. A lot of patients will have very bad bleeding as well. Women who don't decide to have a kid right away are also at higher risk of having endometriosis. Surgical emergency, ectopic pregnancy. And this is why it's important to get a last menstrual period from your female patients of childbearing age. Do you have unilateral pain? Are you having weird cramping feeling? Are you having any bleeding? oh, okay, when was your last menstrual period? Okay, because you can have a ectopic pregnancy in a variety of locations, and the rupture can be deadly. Okay, as you can see, this little tiny fetus here is wandering about this area. It's about 2 months of gestational age before a fallopian tube will rupture. Okay, and if that fallopian tube does rupture, that woman is losing her fallopian tube and the ovary on that side. Okay, a lot of rupture can lead to referred pain as well, usually up into the shoulder, and worse upon inspiration. Remember we talked about that acute abdomen, right? So if you bump into somebody on the stretcher and they're screaming in pain way more than you would anticipate, you might see an active abdomen, an acute active abdomen like that in an ectopic pregnancy. I can't tell you the number of times that women have called because they've had vaginal bleeding, and it's just their menstrual cycle. Other issues that can cause menstrual bleeding or spontaneous abortion, pelvic inflammatory disease, labor, any sort of various placenta issues, which we'll talk about, I think, in the OBGYN section. Passage of clots means that the bleeding is at a greater rate than the menstrual flow. So keep that in mind. Women who've had an abortion or a spontaneous abortion, like either it was a medical abortion that was provided by a doctor, or their body was like, "There's something wrong with this fetus. We're not gonna keep growing it." Then this is one of those women who might be having significant blood flow that can cause all sorts of issues, hemorrhagic, hypovolemia, etc., etc. Dysfunctional uterine bleeding. Please see previous slide. It also can be women whose cycles are heavier than normal, soaking through pads or tampons with no possibility of pregnancy, periods that are shorter than 28 days or greater than 35 days, right? So there's plenty of women who have an unpredictable menstrual cycle, who might don't know if they're pregnant or not because of different issues. Again, this is why it's important to, if you have a woman who's complaining of heavy vaginal bleeding, etc., that it could cause different things, and you get a good history and you can kind of have an idea, maybe make her feel a little bit better. Uterine prolapse. People who traditionally have this issue are women who are postpartum, or older women, like much older women who don't have as much circulating estrogen, with significant bearing. Sometimes it feels like there's something in her vagina, or that she's quote unquote sitting on a small ball. Basically, the uterus falls down and out into the vagina. So here you go. Here's some vibes. The fact that the ovaries are still attached and it looks like it's like a waving for help. It can be anything from where you cannot actually visualize the uterus to the uterus fully prolapsing and being external of the body. That's a significant surgical emergency. You bring that to the hospital. Vaginal foreign bodies. There's a whole number of reasons that could cause this, including abuse, including poor sexual education, where people may, I don't know, for example, be like, if I put this sweet potato in my vagina, I won't be able to get pregnant. Lies. Don't do it. Again, it could be anything. Toxic shock syndrome. Okay, this is why you never trust a tampon. Toxic shock syndrome is traditionally caused by a tampon that's been left in for an extended period of time, and or superabsorbent tampons, and or bacteria on a tampon. It's a staph infection and it can spread through the body very, very quickly, okay? Within days. or hours. A very high fever. There's sloughing of the palms and the hands and the soles of the feet. Vomiting, lethargy, altered mental status, right? There's some women who don't even know what's going on, right? And they just, all of a sudden, they wake up in the hospital. It's very, very quick in the progression, okay? This might be one of those things where you're like just dealing with a patient who has an altered mental status and a high fever, and you're expecting it to be sepsis, okay? You're not going to treat it much differently. And you're not going to go looking for a tampon. So just keep that in mind. Important things that you should kind of check with a woman when you're taking a history. Pregnancy. Okay? GPA. Gravida, para, abortion. Okay? Gravida is how many pregnancies. Para is how many have been carried to term. And abortion is how many miscarriages, etc. If you have a woman who is pregnant, has she delivered via vaginal or has she had a C-section? VBAC is a vaginal birth after C-section. It's considered a high-risk pregnancy because there's always a possibility of a uterine rupture along the site of the first C-section. Last menstrual period is important if there is a possibility of pregnancy, missed or late periods, breast tenderness, morning sickness, right? I definitely had to tell one lady once that she was pregnant. I'm like, when was your last menstrual period? She's like, 3 months ago. I'm like, and you're calling today for vomiting? She goes, yeah, I'm vomiting every morning. And I'm like, and when was your last menstrual period? And she's like, 3 months ago. I'm like, have you taken a pregnancy test? She's like, no. I'm like, oh, you go find out soon enough. To the hospital. And women don't necessarily think of that, which is, there's some who just, again, poor sexual education. We just think that, you pray to Jesus and it's going to be okay. Any previous GYN problems, right? Has she had a D&C before? Has there been a colposcopy, which is they take a piece of the cervix out that has abnormal cells, ectopic pregnancies, miscarriages, painful intercourse. What is the present blood loss looking like? Is it dark blood or bright blood? Dark blood kind of indicates that it's been there for a while, and it's an older, maybe like the previous menstrual cycle didn't clean out the uterus as aggressively as before. Bright blood could mean that there's some sort of hemorrhage going on. Okay, is it a normal amount of discharge? Contraceptives, are they being used? Are they being used correctly, right? There's people who, I take birth control. Okay, I only take it when I'm going to have sex. Well, it doesn't work like that, sweetheart, okay? Any sort of trauma, emotional distress, which can cause miscarriages, stuff like that. Try to be kind of empathetic and ensure privacy and modesty. Palpating an abdomen is always important, right? Just remember that lower pelvic region could be very tender depending on what's going on. Do remember that a pregnant belly is a little bit different than a non-gravid belly. Do not pack a vagina. Just don't do it. Don't do it. Sexual assaults are a very kind of hot button topic, I think. About 80% of women have been sexually assaulted at one point or another. 50% go unreported. And that's a best guess because there is a lot of victim shaming in this country. There is a lot of lack of empathy. There's a lot of lack of progress when it comes to actually investigating and tracking down sexual criminals. So it might be a difficult situation to talk to a patient about, but you might have to have that difficult conversation. A number of different injuries that might be associated with a sexual assault, facial fractures, human bites, right? Any sort of trauma to the abdomen or genitalia, including the anal region, your priority is the life threats. Okay, treating the patient kindly. Just be cautious, right? Be kind. I think that's the best way to put it. Don't let the patient shower. Try to handle the clothing as little as possible in the event that actually the case actually does get investigated. A lot of the wounds, make sure this is also you're taking this patient to a safe hospital, okay, or sane hospital, sorry. If you happen to have paper bags and the patient wants to take their clothing off, put those clothes in a paper bag. Paper bags preserve DNA evidence. Despite the fact that, we're really super behind on rape kits. Don't get me started. All right. Questions, thoughts, concerns? That's gynecology for you.
So I know if we had a case before where I had to transfer a patient, and obviously I didn't know at the time, but there was a young daughter was raped by a family member. The family member was present, so it was very hard to investigate who was it, what was going on. So we just obviously had to take care to sort of remove any adult that the patient feels uncomfortable with. It's very sad. The person is very young.
Yeah. Unfortunately, that is challenging. It's a very difficult kind of situation, especially with the younger. And that might be one of those times when you might want to try to separate the patient from family and kind of utilize the police to help you kind of get them.
Okay.
Yeah. I see the question on here that it's not a safe hospital, it's a sane hospital. There's specialized nurses that actually will I have a friend who actually is a sane nurse, who they know how to process the rape kits, how to collect evidence, and how to provide kind of psychological assistance to this patient who's just gone through something really bad. LIJ is one. Stony Brook University is one. I think Newmick is one. Queens Hospital 38 is one. Don't ask me about Manhattan. I'm not sure. Or Staten Island.
I think Winthrop is one, right?
I don't think so. I don't think Winthrop is one.
I think I saw like a small little sign on the wall that says
Sane?
something sane. Yeah.
It might be. I'm really not sure. I'll look it up. I'll look up what the sane hospitals are. Sane hospitals. Cohen's, Pizza Cohen's. There you go. So yeah, it's one of those sensitive situations for people, because, as I said, there's a lot of issues in this country where we're like, I saw a really great ad. It's like, oh well, she was whatever that woman was wearing, she deserved it. And so like this guy standing there with like a soccer jersey on, and she goes, oh, and knocks the brownie he just ordered off his plate. She goes, you should really get back to training. You dress for what you expect, right? And she's like, you're a soccer player. I was gonna say footballer because it's a UK ad. Oh, you're a soccer player, so you shouldn't be eating this. Kind of like, because they were talking about the ad. I'll see if I can find it. I thought it was really well done. There's an artist who actually did an entire piece about what women were wearing when they were raped. Because we talk about, you're just too provocative. Like, yeah, how about some respect for other humans is really a bigger issue. And a lot of the clothing that she put up was like a t-shirt and jeans. Like, not something where you're like, oh well, she's walking around totally naked. Like, even if you were, consent says no. Just don't be an asshole. Anyway, all right. We have one last lecture, and we're good. So let's do that. I don't even remember what it is. I think it's hematology. Come on, hematology. There we go. Hematology. I'm going to say the one main thing that you really should know about hematology is sickle cell. Okay, sickle cell is probably the most significant hematological emergency that we're going to be dealing with. Secondary to that is going to be any sort of bleeding disorder. And I'm blanking on the name right now, but we're going to talk about it in a moment, so I'll get to it then. Blood. Blood is really exciting. It does a lot of things for the body. It transports all of the things that we need from one place to the other. It provides us with that mobilized immune system, and it helps us with the acid-base balance, right? It keeps us at homeostasis. It's also really fun when you are a crime scene investigator trying to figure out who murdered whom. Your bone marrow is where blood is produced. Red bone marrow is primarily in your membranous bones, your vertebrae, pelvis, sternum, and ribs, whereas your yellow, bone marrow is what produces your white blood cells. And a lot of you have both red and yellow bone marrow in your long bones. So, for example, your tibia, fibias, femurs, etc. When you are inserting an IO into a tibia, one of the processes of ensuring that you're in place is to draw back, because they want to see if you get marrow. So when you draw back, you might see yellow marrow in the bone, which would indicate that you are in fact in the right location. So if you do happen to start an IO and you do that pullback, you'll see like a kind of like straw colored yellow. Your spleen is super helpful for you. It's not something we think about very often. It stores a very large quantity of blood. I want to say about up to 1 liter of blood. So in the event that you are going into some sort of hypovolemic shock, your spleen is like your backup storage, and it's like, release the blood. And it will like release this blood and give you a boost. So patients who have had their spleen removed for various reasons, such as trauma, really just trauma, don't have that extra boost that kind of keeps them safe. Give them a couple extra minutes. It also produces lymphocytes and plasma cells and antibodies that kind of helps support your immune system. Your liver also helps form blood cells while you are a fetus, but as you move into humanhood, it also helps create the coagulation factors that keep you from bleeding out on the regular. Things like albumin, which kind of becomes lower as you move through your acute phases. Complement factors, there's a lot of different factors that kind of are involved in blood clotting, factor 10, Christmas factor, there's a lot. So blood is made of a lot of different components. Hemoglobin is probably your most abundant cell, or red blood cells, which hold hemoglobin, are your most abundant cells. Every red blood cell lasts for about 120 days before it's broken down by macrophages and filtered out by the liver. When it's being filtered out by the liver, it produces bilirubin. So bilirubin, and this is like parents, if you have a child who's born with jaundice, it's because of bilirubin. They put the little baby under a little UV light, and they like kind of photosynthesize the bilirubin out of their system, and they're fine. Okay, it just means that their liver hasn't caught up to them and being like an out of utero baby. This is also the bilirubin is the component that turns patients yellow when they have liver failure. Okay, right? So those alcoholics, those Hep C patients, et cetera, bilirubin is that yellow yellow coloring that you get. On top of the red, next to the red blood cells, we have plasma. That's the clear portion, right? It carries a whole bunch of different compounds. It is made of 92% water. This is what is affected by multiple myeloma. The other components that it carries around is albumin, which is a protein, other globulins, which are proteins, and fibrinogen, which is one of the components that helps you clot. Then you also have white blood cells, right? White blood cells, if you don't have an infection, are kind of at a low-key level. They don't have There's not a lot of them floating around. There's just enough to kind of be the watchtower version of, your immune system. They float around. They go, oh, you don't belong here. Let me call up the troops, and the white blood cells come to the rescue. And then you have platelets, okay? So platelets are these little teeny tiny cells that help create clots, okay? When they work normally, they're great. They do a really good job. When you have an over-enthusiastic response of the thrombocytes, you can end up with clotting disorders, coagulation issues, MIs, strokes, all stuff like that. So let's talk about that a little bit. Homeostasis. Homeostasis is your body's response to anything that kind of throws it out of whack, right? So if you are bleeding, it will create or release platelets so that the bleeding stops. If you need to, if you have an infection and you need white blood cells, it'll happen. When it comes to bleeding, when there is a break in the continuity of the endothelium, that's what sends out the message that it needs platelets and it needs clotting factors, okay? And that can be an internal or an external situation, right? Because think about, right, an MI. An MI is the clot can be caused by a clot formation inside a coronary artery. You might have had a rupture of that endothelium in the very inside of the cell because of turbulent blood flow, that now all the platelets are being called over to come fix it, and it blocks off the artery instead. Or you can cut your hand slicing an avocado and you have an external interruption of your endothelium, and it's going to do the same thing, okay? And it sends all the, the white blood cells and everybody else to the location in order to help fight any potential infection. As that fibrinous tissue is laid down, right, that fibrinogen turns into fibrin, and it becomes a hardened clot. All of that starts to regrow, and once it starts to regrow, it starts to release the clotting factors that break everything down. So this is what we were talking about before, right? You have an intrinsic pathway. There's some sort of internal injury that needs a blood clot. So it goes down through this pathway, and you're not going to need to memorize this pathway. Or you have an external tissue injury, which then creates a slightly different pathway, right? Because it skips some of these guys, the Hageman factor, because it starts with thromboplastin, and it goes all the way down into the common pathway where blood clot is formed. Now, just a quick look at this. Look at the calcium involvement. Okay, hold on, let me get a pen. You have calcium here. You have calcium here. You have calcium here, and here, and here. Calcium is involved with the conversion of a lot of these factors to the next stage. So if you have a patient who is hypocalcemic, they might have a very hard time clotting appropriately, okay? Going back to your liver, this is also part of the reason why alcoholics bleed so much. All of these factors, right? You've got 12 and 11 and 11A and 9 and all of these guys, right? All of these doodads, these various factors help you clot. Your liver can do one thing at a time. And if it happens to be breaking down alcohol, it won't be able to produce clotting factors. So now you have all this alcohol floating around your system and you have no clotting factors, and you happen to, fall down, go boom, and strike your head. There's none of these factors around to help you stop bleeding. Okay, and this is why you see alcoholics who have a lot of bleeding problems due to very minor traumas. It takes about 7 to 10 minutes to form a clot in a healthy individual. All bleeding stops eventually, right? Hopefully within 7 to 10 minutes. If it is going longer than 7 to 10 minutes, you may have a problem. Here's some problems. Anemia. Super popular, super common. A variety of different anemias exist. You can have pernicious anemia. You can have vitamin B12 anemia. You can have iron deficiency anemia. You can have hypovolemia anemia. Okay, a lot of different things that can cause problems. There's a type of aplastic anemia, which is a leukemia, which just destroys red blood cells. Okay, a lot of different things can cause anemia, and it can also present in a lot of different ways. Okay, so you might have a patient who's presenting with chest pain. Okay, one of the best things you can do for a patient is to check inside their eyes, like right here, like right along here. If you have a patient who, like, this inside part of their eye is like really, really pale, highly probable that they are anemic. Okay, it might be because of a bleeding. It might be because of low iron intake, right? And sometimes it's also whatchamacallit, it might be due to lifestyle choices, right? Vegans and vegetarians, they don't eat meat. They might have a lower they have a lower red blood cell or hemoglobin count if they don't replace their iron efficiently. Okay, plant iron is not always absorbed as well as animal iron because of what it's mixed with. Okay, so for the most part, iron is not absorbed without vitamin C. Iron is not absorbed when it's paired with calcium. Okay, so if you have somebody who's like, oh, I'm doing all the right things, look, I'm eating this and this, and it's okay, but you're pairing your nutrients inappropriately. So this is why you're not necessarily absorbing the nutrients, and you're still potentially very anemic. Just things to keep in mind. It's one of those questions that you can ask the patient while you're getting a good solid history. Patients who are on dialysis and stuff as well can have an issue. Pernicious anemia is due to vitamin B12 deficiency. Again, vegans and vegetarians commonly have a B12 deficiency. They need to supplement this vitamin in order to be appropriately not anemic, I guess. Fun fact about B12. B12 actually makes your red blood cells quote unquote fluffy. I swear to God, I saw this in a scientific journal. It makes the red blood cells kind of fluffier and plumper. So if you do have a patient who's maybe had a recent MI and stents placed, if they're anemic or they have pernicious anemia and they're supplementing with B12, they could actually create their red blood cells to be too fluffy to make it through narrowed coronary arteries. Thank you for coming to my TED Talk about pernicious anemia. Iron deficiency anemia, right? So we talked about this already, right? If you don't absorb iron appropriately, you won't have good binding capabilities of your red blood cells. If you have these little small inefficient red blood cells, you're not going to be able to move oxygen around the body as well as you think you are. So you can have a patient who has great, red blood, but it's not iron dense, and they're not moving the oxygen efficiently. So again, they could be having stuff like chest pain with exertion, dizziness, stomach pains, all sorts of other stuff from just a lack of oxygen getting to where it needs to be. Really bad anemia can present as a number of different things that you wouldn't expect it to look like, right? So that's why you got to keep those things in the back of your mind. Other reasons that a patient might have iron issues, okay, so women right off the bat have an increased iron requirement because of menstruation, right? They're losing 20 to 60 milliliters of blood a month. That's 60 to 25 milliliters of iron-rich blood that is no longer floating around. Anyone who is on some sort of specialized diet might require have issues, right? Here, decreased intake and malabsorption. People who drink coffee, right? Coffee and iron. Caffeine reduces iron intake. So maybe you are a person who has an increased iron requirement, but you happen to be taking your iron supplement with a cup of coffee. It's not going to absorb. You need to take your iron supplement with a vitamin C supplement. increased iron loss. So patients who maybe have like a slow GI bleed due to diverticulitis or an ulcer or whatever, people who regularly donate blood, NSAID use, aspirin use. Okay, so anybody who is a cardiac patient, right, who takes aspirin on a regular basis or blood thinners on a regular basis might have an increased loss of iron. Elite athletes. Interesting thing about elite athletes. While they might actually lose iron, it's traditionally their ferritin levels, which is their ferritin is a protein that stores iron in the body. It's traditionally the ferritin that's actually lower than because they'll test well as like, oh yeah, no, you're good, like your blood count came out good, but they didn't check for ferritin. Ferritin deficiency can present with serious fatigue, all the same kind of symptoms as anemia, but won't necessarily be caught in a traditional blood test. It's one of those like, check this also, that people don't know about. And a lot of doctors don't necessarily check for because they don't, PCPs aren't necessarily checking for it. Red blood cells, if you do happen to exercise a lot, every time if you're running or something, every time your foot hits the ground, that impact actually destroys red blood cells, which is kind of an interesting little tidbit of information. So if you have somebody who has a very intense workout regimen, that might be a question that you're asking. What is your workout regimen? Do you supplement iron? Do you do any other number of things? What's your diet looking like? Hemolytic anemia is considered possible. Is related to cancers and autoimmune diseases or other inherited disorders. So basically, the body breaks down red blood cells faster than it should, so you're always just at a loss. Because remember, red blood cells are supposed to be good for about 120 days. So if you're losing red blood cells faster than you're making them, you're going to be at a deficit. Come on. Why we no go? Thank you. Also, it could be that the red blood cell is not the right shape, right? So we look at red blood cells as these sort of round, sort of pool floaty kind of items that kind of go around. And if they're not in that really round shape, one, it's going to be hard for them to get through the blood vessels. And two, the body's going to be like, this isn't right. This doesn't look right. Let's break it down. Let's start over, right? So there's two different versions of hemolytic anemia that's really kind of common. The first is sickle cell, right? Sickle cell is genetically linked to African Americans, and the red blood cells are shaped like a crescent moon, okay? Because sometimes people don't know what a sickle looks like. So a crescent moon, it's not efficient at carrying oxygen because the hemoglobin hemoglobin likes to be in a circle, okay? Those iron molecules like to be in a circle. So if you have a blood cell that's shaped like a crescent, it doesn't work. Also, these cells get stuck, okay? When you get these little junctures where they need to go, especially around joints, right? Because think about if you kind of crick your elbow or bend your finger, those going around that corner is hard for something that has pointy edges, okay? So if it's not appropriately shaped, it gets stuck and it's very, very painful. Basilemia is, I believe, more associated with the Mediterranean genetics. So Greece and Italy, like a lot of that area where, kind of, I don't know, interacted with African descent people, trade routes. Basilemia is not as dramatically misshapen. I think it's more square than crescent moon shaped. But again, you still have this issue where these cells become trapped and they then get broken down by macrophages and aren't doing what they're supposed to do. Hemolytic anemia can also be caused by malaria. So if you happen to be traveling to one of those exotic locations where the mosquitoes are extra deadly, it will go and destroy some of the red blood cells. Autoimmune diseases also destroy red blood cells with antibodies. There's a lot of different reasons that the blood cells can be destroyed. But again, you're looking to treat the patient's overall prognosis and picture. if your patient happens to have thalassemia or sickle cell, you might actually ask for pain management, which might be the only difference if the patient's in significant pain. But these are patients, and also sickle cell and thalassemia might require a fluid bolus, whereas regularly anemia you would not treat with fluid. Think of it this way. If you've got about 4 red blood cells bouncing around in your vascular system, do you want to increase the space between them with fluid?
Negative.
Negative. Not a good look, right? Because now you're really stretching out the red blood cells and you're reducing your efficiency of oxygen transportation. So unless that patient's severely hypovolemic, right, and they're got a blood pressure of 80 because they're anemic secondary to blood loss, you're not going to bolster them up. Sickle cell and thalassemia, yes, because you want to thin out those irregularly shaped blood cells so that it might be easier for them to get around corners and stuff in the blood, the vasculature. Little tip. What else we got? All right, so we talked about this a little bit, right? So fatigue, headaches, brittle nails, right, from poor circulation. Also, brittle hair could be a possibility, again, due to poor circulation. Sores in the mouth and tongue are very popular or very commonly seen. Chest pain and shortness of breath, I want to say, are probably more your traditional, that up there with fatigue, right? Because think about it. If you're not able to transport enough oxygen, you're going to feel short of breath because your body's screaming for more oxygen. And that chest pain is because that heart is screaming for more oxygen. And if you aren't able to supply it because you have, decreased red blood cells, this is what you're going to be presented with. There we go. All right, so we talked about sickle cell. All right, so they're very fragile. They're really misshapen. They cause all sorts of ischemia. Patients with sickle cell also have an increased risk of coronary artery issues, right? Sort of like MIs, PEs, stuff like that. Keep that in mind. All sorts of other issues. Priapism in male patients who have sickle cell disease is a very commonly seen. Strokes, right? Any sort of problem that might be caused by a clot. And this is why, right? Because we talk right here, dehydration can cause a sickle cell crisis. If it starts to get too, like those red blood cells are too close together, they're going to have a hard time making it around corners and bifurcations. Any sort of extreme stress on the body can cause issues similarly. Aplastic sickle cell, right? The bone marrow temporarily stops producing the red blood cells, or the red blood cells get broken down too quickly in hemolytic sickle cell. And then you have sequestration, which is where the spleen starts to kind of, either on purpose or because it's getting stuck, kind of put some red blood cells aside, okay, for storage, thinking that, oh, there's going to be a problem in the future. This is why the spleen is super helpful if you have a otherwise healthy patient who's going into hypovolemic shock, because it can de-sequester the red blood cells to kind of help move some more oxygen around. If you do have a patient who is having a sickle cell crisis, we're going to kind of stick here on these three in our management, where you're going to give the patient oxygen, IV hydration, and pain management as needed. Okay, we aren't going to fiddle with the electrolyte replacement, because even if you called and got permission or asked for permission, most of the time the doctor's not going to give you electrolytes. That's the hospital's going to want to get a baseline in the first place to find out what needs to be tweaked exactly. But this is our main bread and butter right here: pain management, IV hydration, and oxygen. We did that already. So here we go, little variations in red blood cells. We like these little donut-shaped pool floaty guys. Now, moving on from red blood cells, leukemia, right? Remember, emia is blood and leuc is white, is a cancer of white blood cells, where there's usually too many white blood cells going on. And because the body's making too many white blood cells, normal red blood cells, platelets, and normal shaped white blood cells are not being made appropriately. So you can live with leukemia. They can manage it and kind of keep it at a chronic stage where it's not overdoing it. Or you can have to go through the full treatment where they do like a bone marrow transplant. So it's really dependent on, like, I guess, the severity and the way that it's affecting the patient's body. But an acute stage leukemia is when you have a lot of the cancer cells are coming in early, and then the chronic is it's being managed, but it's able to be kind of kept under control before the cells are fully made into white blood cells. So there's a number of different classifications for leukemia. You have the acute lymphocytic and then acute, myelogenous. Acute lymphocytic is usually for children. The other one is usually for like middle-aged adults. Leukemia is one of those cancers that you kind of do see more in children, unfortunately. There's such a large amount of white blood cells that they start to accumulate in all sorts of like the end vital organs, and that's what kills you more than anything else, is that there's so many white blood cells that it starts to shut the organs down. A lot of the signs and symptoms associated with leukemia is kind of just challenging, I guess, to specify depending on what's going on with the patient, right? Because if you look at it, it's kind of generalized issues: fatigue, some bleeding, bone pain, like aches, pain, headache, frequent bruising, right? Frequent bruising and like usually bleeding from the gums because the body's not able to make enough platelets to be normal, swelling in the lymph nodes. So a lot of these issues, especially could be taken as an infectious process. But without further investigation to find out what's going on, it would be hard, to say one way or the other. And a lot of people would ignore a lot of these issues until it becomes so bad that they go to the doctor, and who knows at what stage their cancer is at that point. Now, on the other side of leukemia, you have lymphoma, which sometimes can be associated together. They have Leukemia and Lymphoma Society, right? These are more of your blood disorders. Lymphoma is more of a rare cancer than leukemia. And it takes place as abnormal cell growth inside the lymph node system, right? And you have Hodgkin's and non-Hodgkin's lymphoma. Hodgkin lymphoma is kind of very painless, progressive enlargement of the lymph nodes and the spleen, okay? Non-Hodgkin lymphoma is a little bit more on like the aggressive side, and a little more on like the cancerous neoplastic side, where Hodgkin lymphoma might not necessarily be malignant. Non-Hodgkin is. Like there's a few rare Hodgkin lymphomas that are not cancerous. Most of the time, lymphomas can be caused by viral infections, okay? Especially Epstein-Barr. Epstein-Barr, they're doing a lot of research on because they seem to be finding that it's associated with a lot of different diseases. But at the same time, it's one of those viruses that like 80% of the population of the world has been exposed to and has had at one point or another. So is it really a true correlation? Unclear. So they're doing a lot of research on that. So we talked about multiple myeloma again, so we're just going to review it real quick. The body produces too much of the protein M and plasma cells, and it starts to accumulate in the bone, which causes a lot of bone pain. It starts then also impair tissue function, especially the kidneys. Okay, so the more that these big old abnormal plasma cells start floating around, they start to do damage to all the end tissues. Polycythemia is too many red blood cells. So almost every single COPD patient probably also has a diagnosis of polycythemia as well. Most of the time it's caused by a response to chronic hypoxia. Sometimes it's a weird little like, oh, you just made too many red blood cells. But it also could be associated with dehydration. Now, not a true polycythemia where like it's an overproduction, but there's not enough plasma in your blood system for the red blood cells to be far enough apart, okay? And it's sort of like when we're talking about sickle cell, same kind of concept. Moving on. So primary polycythemia is just an increased red blood cell. Now, as you have increased red blood cells, the blood starts to become thicker and more viscous. Okay, so that high viscous blood means that your blood can be more sticky, that you have an increased risk of throwing clots, and having all sorts of other kind of secondary issues, in a large spleen and in a large liver, for example. Now you can also, that's like, a main disease process that they can't find another reason for. You can also have secondary polycythemia, which is, again, we talked about, like COPD. People who live at high altitudes, right? Because they need to move more oxygen because the atmosphere is thinner. So this is why, like, a lot of elite athletes will go and spend time at higher altitudes right before a big race, because they're trying to, it's especially blood doping, right? They're trying to increase the amount of red blood cells that carry oxygen, so when they come back down to sea level, they're like super awesome because they just are able to transfer more oxygen. Patient might have blurred vision, some dizziness, itching, red hands and feet, other things. There is a really good episode of House where they deal with DIC, which is disseminated intravascular coagulopathy. Okay. DIC is commonly seen in patients who have had significant trauma or significant sepsis. It also can be caused by issues secondary to pregnancy, because pregnancy isn't scary enough. But those three are probably the most common. And then you also have, like, if there is some sort of organ destruction or malignancy that is going on. So basically what happens is the body starts to bleed. And as it starts to bleed, it starts to try to bring clotting. So as it starts to try to clot, it runs out of its clotting factors, and then you just bleed. So it starts to throw all these microclots around. And as these microclots kind of go throughout the body, they end up in fingers and toes and capillary beds in the heart and in the lungs and all sorts of other locations that are kind of important. But as the body starts to run out of the clotting factors, then you start to bleed from other locations. So you are simultaneously throwing clots and having, like, mini strokes and, ischemic fingers and heart attacks while you're also bleeding out. So it's a very careful balance between trying to get the patient to remain thin, like heparinized, because now they have to try to keep you from clotting, but they also need to keep you from bleeding out. It's very challenging for doctors to balance, and this is not really something you're probably going to see in the field, because this happens like days after trauma, okay, or days after, like, sepsis starts to set in. It's one of those, like, progressive kind of situations. So here we go. This is what happens. The body starts to make too much thrombin in response to an insult. And then as the platelets and coagulation factors and thrombin are used up, the patient starts to bleed. And then you have the deposits in microcirculation, tissue damage, red blood cell damage, multiple organ failure. It's just not a good situation. But as I said, there's a good episode of House where they deal with this. There's, like, a ballerina who ends up, I think she was septic or something, and they have to, like, inject heparin into her fingers and her hands to try to keep the ischemic tissue damage under control while they were trying to plug her full of vitamin K on the other side. It was interesting. Hemophilia. This is the word I couldn't remember before. Hemophilia is a genetic problem caused by a lack of one of the clotting factors. Okay, and it's dependent which hemophilia it is. It's dependent which factor is missing. So, like, where along the pathway you are running into an issue. So in hemophilia A, there's a missing factor 8, right? So if you look over here, factor 8 is right under extrinsic pathway, right? So if you have some sort of significant injury, you won't necessarily bleed, or you won't necessarily move down the common pathway appropriately because you would never develop, or sorry, that's factor 8. Where'd factor 8 go? Here it is. Just kidding. So you have an intrinsic pathway, right? You're not necessarily going to create factor 10 because this factor is missing. Okay. 9, factor 9, or Christmas disease is up here again. You won't make it to factor 10 if this factor is missing. And then you have von Willebrand, which is one of the more commonly seen hemophilias. There's a missing von Willebrand factor, because if your name is von Willebrand, if you have not named something after yourself, you're really missing out. It again happens over here in this corner of the intrinsic pathway by factor 9 and factor 8. Von Willebrand doesn't make factor 8 happen. So it's sort of like a step above hemophilia A. I do believe von Willebrand can be treated with infusions of von Willebrand factor. I think that that's a thing. But these are patients who, they have minor dental work, or they have an injury and they won't stop bleeding because they're not making it down to the thrombins and the fibrins that formulate a blood clot. If anyone wants to go down a historical rabbit hole, this was the Anastasia's family, the Russians. I'm blanking on the last name. Her younger brother had hemophilia, and this is why they had Rasputin come in. He was supposed to be like this witch healer who was going to help with the hemophilia, and then he just caused issues. Moving on, thrombocytopenia is a low platelet count, okay? So you, again, have a lot of just random bleeding going on. Well, most of the time, a lot of the bleeding that you kind of see is in the teeth and the gums, along the gums. Patient will have various petechia and purpura. So petechia is associated with small blood vessels bursting under high pressure. Purpura is a slightly larger blood vessel that's bursting. So you'll have like this kind of like almost like freckles, or like a blood spray of like just little bruise, like little blood spots underneath the skin. These patients are commonly given platelet infusions to kind of help them feel better, but it's usually secondary to another issue, right? So leukemia or lymphoma, aplastic anemia, which is cancer, another type of anemia, infectious diseases, etc. So you can have an idiopathic version, or you can have a thrombotic version of thrombocytopenia purpura. Idiopathic is usually the antibodies after an infection response, while the thrombotic is after some sort of like trauma or other pregnancy issue or something like that. You're not going to need to know the difference. Just know that having those little random spots, like blood spots all across the skin could be a sign of thrombocytopenia. Okay. Come on. Whoa. Cool. All right. So, thoughts, questions, concerns? No? Feeling okay? All right. I see here in the chat that Scott has an update for Medicat for anyone who wants to stay on and get an update on what your status is. Other than that, if you guys have no questions, have a lovely Labor Day. Don't work too hard for those of y'all who are working. Enjoy that holiday pay. All right. Have a good.
Nicole.
You're welcome.
Thank you, Nicole.
You're welcome. Have a good day, guys.
Yeah.
All right. Bye.
Nicole.
Oh, and remember Thursday, 8 a.m. If you can make it, I'll send out a Zoom for the cardiology remediation.
And it will be recorded, right?
It will be recorded.
Thank you, Nicole.
Yes. If you have any questions, thoughts, or concerns, please bring them to the meeting so we can go over them. All right. Bye.
Bye.
Yeah.
Happy holidays.
Happy holiday.